good morning.
Hello. How are you, Paul? Good evening.
I'm very well, thank you. So we have, just to introduce everybody, so I'm Paul Mason. We have Dr. David Diamond, or rather Professor. For people who don't yet know him, David is very accomplished in the field of neuroscience, but he's also got a passion for lipidology, and he's very, very well published in this field. And Dr. Nadir Ali, you see in the bottom left of screen here. Good morning, Ali. Nadir. It's you're a cardiologist, also passionate about lipidology, and as we're also fortunate to have Dr. Gary Fettke from Tasmania up in top left of screen, orthopedic surgeon, really needs no introduction in the low-carb world, has really made a path for others to follow, like myself. He's taken on vested interests and is still doing so, and is a force to be reckoned with. So welcome all.
Thank you.
So I might just ask for some opening comments if you'd like to comment on something you've seen in any of the presentations thus far, or just a comment that you'd like to make that you think is worthwhile for discussing further today. So I'll start with Gary. Okay, it looks like we don't have Gary. Let's go on to David.
Well, let me just say I have great admiration for the fellow who just spoke, who took charge of his health by adopting the low-carb, high-fat diet, and using Diet Doctor, getting good medical advice. He didn't raise the issue of cholesterol, but we all know that this great concern is that every biomarker moves in the right direction. You lose weight, your blood pressure's down, your blood sugar's down, you're feeling phenomenal. But if that cholesterol happens to tick up, well then so many physicians, especially cardiologists, want to put you on a statin because they'll fear you have a heart attack. And you're at great risk for a heart attack. And I can say 20 years ago, I was a bit heavier and I had extremely high triglycerides and extremely low HDL. And I didn't know much about either one. And in a sense, I wasn't obese. I was about 15 kilograms heavier, about 30 pounds heavier than I am now. But my doctor told me that I increased my risk for heart disease if I went low carb. So, I decided to do the research on my own. And here I am 20 years later. I've improved all biomarkers, although frankly, my LDL is still 200. My total cholesterol is 300. And I happen to be a genetic anomaly. I don't have ideal lipids, but everything else is great. And I think this is something we really need to understand better. And this is why I'm passionate about moving not only I study neuroscience, but I also need to study heart disease for my own personal benefit and from I learned from the three of you. Frankly, I also want to add I'm in awe of the three of you. Outstanding clinician scientists. I mean, you guys have helped me to learn more about my health, and I'm just really so pleased to be able to share it with everybody else.
Well, thank you, David. So might just have an opening remark from you, Nadir.
I want to echo what David just said, and I'm just totally honored to be on the same platform as Gary Fettke. I've been a long time admirer of his. He's taught me a lot. I have shamelessly used a lot of his slides, as well as David and you, Paul. And I think that I just want to end by saying that one comment that David Diamond made about people going on a low-carb lifestyle, predominantly animal-sourced food, fasting, and they see a skyrocketing of their LDL, and it creates such a conflict between them and their physicians, and it creates a level of anxiety in both of them that this is going to ultimately kill them. And I think that this session is very important to dispel that myth, but also perhaps there are some nuances that we need to get into, in the sense that one size does not fit all. And when we get a chance, we will discuss into the nuances as to which particular person is one in whom we need to be careful and say, hey, just going on a low carb, high fat, animal source diet for you may not be enough. You may need to make a certain few modifications. So we should not make the same mistake that we stereotype everybody like mainstream medicine does into one category. So I hear from Gary next, and from you, Paul.
Lovely, thank you, Gary. Good morning.
Look, it's just good morning. I don't know what, it's probably still night for a couple of you. Look, Paul, thank you for putting this together. I've watched all of the talks so far, and I've been a seasoned campaigner here for a long time. I've learnt something from every one of you. Okay, and I haven't heard David and Nadir speak yet, but I've seen your past work, your past talks. I've previously introduced Paul at a meeting. I might have been one of the early vocal proponents. I'm not banting. I wasn't around the previous, couple of hundred years ago. But that complex of, refined carbs, sugar and polyunsaturated oils, that's my topic of nutritional inflammation. And what, that's just a big jigsaw. I saw that, and I'm very fortunate to have seen it, and got me into all sorts of trouble. Welcome to Tim Noakes in my life. But what Paul's doing, what Nadir's doing, what's David doing is they're filling in all those gaps in the jigsaw puzzle so that others can see it. And so we're all part of a big team putting together a big jigsaw puzzle to actually clarify what it is for the wider community. And I think, Nadir, what you got right to the point there, that there's so much misinformation out there which needs to be debunked, dissolved, and then re-educated. And the medical community are the first ones that need to be, that to be done to. And that's where Belinda's work comes in, about trying to work out all those vested interests that have actually been responsible for the disinformation, the deliberate misinformation. So look, I've learnt stuff from the three of you, and I'm looking forward to learning a bit more.
Excellent. Well, I think there's probably a couple of topics of discussion that will probably utilize the talents of you three gentlemen. And I think the first, I'll put them out there. So the wider concept is use of LDL as a surrogate marker for overall health, and how that has led to the distortion of nutritional science, where we blame ancient foods rich in saturated fat for diseases of modernity. So I think that's the bigger conversation of both about saturated fat-rich foods and LDL, and how on God's green earth did we come to assume that people with high LDL levels were perched on the edge of their perch and they're about to drop into the bucket. It just makes no sense. And then I'd probably like to touch on a couple of things just heavier with LDL and some of the root science, while we've got some of the true scientists in this area on the field. And I do actually count both Nadir and David as deep thinkers in this regard. Very few people know as much about the pathophysiology of atherosclerosis and lipidology as you two. And I probably want to delve into some of your comments, Nadir, about the nuances and differences between individuals. And I've probably got a few thoughts on that myself. So I think we might just start with the general concept of use of LDL as a surrogate marker for disease, and how that's led us up the garden path. So I might start with you, Gary.
Well, I thought I'd defer to the other two. Look, I think it started in 1920s, 1930s. I blame the microscope for a couple of things. I blame it for the cholesterol myth, and I also blame it probably for the genetic model of cancer, because that's what you looked down the microscope and they saw. So in those early cases of cardiovascular disease, they looked down the microscope and they saw cholesterol plaques. They were able to start measuring cholesterol. I think it was 1923, David, I think that was about right. So they had something to measure. And so as a result of that, the medical profession love finding things to measure, which you can, and then quantify, and then actually try and come up with a way of treating it. Unfortunately, and I'm not the only person to have used this comment, cholesterol was seen at the scene of the fire. The silly thing is that's part of the cleanup mechanism. Why on earth did we start then blaming the firemen for the fire? And then, and now the concept of cutting funding for the fire brigade to actually treat the disease. So that's, brief history. That's my take on cholesterol from where it started. But as time went on, we started looking to find other particles, and I actually don't like utilizing just LDL numbers. If we're going to ever apply anything, it should be a whole lipid subfraction analysis, and then start delving into that and how that all works. The LDL cholesterol is when they started looking down and saying, okay, which particles within this overall profile could be responsible. And very much like we've now debunked cholesterol as a true marker, we're in that phase now of actually debunking LDL cholesterol. And the thing which comes across most healthcare professionals' desks is that LDL, which is actually not a number. It's actually part of a subtraction equation. And yet we've, the whole industry, that whole, what I call, big public health, pharma, have got an enormous vested interest in finding a criminal, then finding some way of actually demonizing it, and then actually finding a drug to treat it. And as it's turning out, it's not the LDL-C, it's not HDL, it's part of a very complex picture. And I'm going to, that's the brief history of it. We've started, now the entire pharmaceutical industry and medical industry can't actually admit they got this one wrong, to say statins are actually harmful. Imagine the amount of blowback.
Let's just pick up that thread for a moment there, Gary. So you've just introduced the pharmaceutical companies and the concept of statins. So some people may argue that it's actually this, I guess, the link, the purported putative link between saturated fat ingestion and LDL that has only been perpetuated because we have a drug to reduce LDL. And in the absence of a pharmaceutical which could be profitable, perhaps there would be less resources thrown at encouraging the persistence of this notion. David, I don't know if you think that would be a fair assumption, fair assessment?
Well, let's remember a bit of history, that long before there were statins, we had corn oil. And corn oil very effectively lowers total cholesterol. Corn oil sells itself. It began in the 1950s with Ansel Keys. And you had this study by Rose in BMJ in 1965, in which corn oil was explicitly used to lower cholesterol, presumably lowering risk of heart disease in men as a secondary prevention. And so corn oil by decades preceded the statins. And you look in the ads right now, corn oil is sold, and they say it's superior to olive oil because it lowers cholesterol more than olive oil. And everyone seems to have neglected that critical study published in 1965, which showed people died at a higher rate taking corn oil, a couple tablespoons of corn oil every day, compared to the placebo.
And this was shown in three, so the Rose study, the Sydney Diet Heart Study, and the Minnesota Coronary Experiment all showed that.
Exactly. Right. So, well, there you're exchanging saturated fat for polyunsaturated fat. You're lowering cholesterol, and people are dying. And I believe it was Abramson at Harvard who said, dying with a lower level of cholesterol is not a successful outcome. So I think the industry was there. The food industry was present decades before the pharmaceutical industry. And I have to tell you, in 1984, cholestyramine was given over about 7 years to men who had extremely high cholesterol, probably a good percentage with familial hypercholesterolemia. And in fact, there was no effect because cholestyramine is relatively specific to LDL. No effect whatsoever, no statistically significant effect, but they artificially changed the statistics. They took an 8-band difference out of over basically hundreds of thousands of men in the study, and they created an effect, which then ultimately led to statins and now the PCSK9 inhibitors. So I just want to get some broad perspective that we have industry, including the food industry, selling reduction of cholesterol. I mean, think about it. We have herbs, we have garlic, you name it, Cheerios. I mean, if you look at the box of Cheerios, it's got a great big heart on it, and the ads say, you're eating Cheerios because you're lowering your risk of heart disease. And there was some trivial difference in cholesterol in some study, probably run by the Kellogg's, show lower cholesterol. So it's not just medication. It's any food that lowers cholesterol is seen as a cardiovascular benefit. And of course, there are no actual events that have been shown to benefit, but just having this surrogate marker is a great way to market your product.
Yeah, and I guess you made two comments there that was interesting. So one of them referred to, dying with low cholesterol not necessarily being a good outcome. So LDL is a terrible surrogate marker. If we're concerned about living longer, we should actually measure living longer. And the other comment you made was about the replacement of saturated fat with seed oils, polyunsaturated oils. And the interesting thing there is that forever and a day, we've been told that ingesting saturated fat increases LDL level. And that's not the correct way to think about it. You stated it just then. Zoe Harcum very eloquently discussed it in her lecture as well. It's not that saturated fat increases LDL. Mechanistically, that's not plausible. It just doesn't happen. It's that plant sterols contained within seed oils lower LDL cholesterol. And for all intents and purposes, as in Zoe's publication when she did a review of the data, yes, plant sterols effectively do lower your cholesterol, but no, they don't help you live one extra second. So I think we actually need to educate people that it's not that saturated fat increases LDL, and I might get your comment on this too, Nadir, but rather that plant sterols found in basically things that don't contain animal saturated fats, that reduces cholesterol rather. So let's actually talk about directionality and causality correctly. Thoughts, Nadir?
Sure. Yes, I would agree with Zoe about her work. And there is a very tight correlation between phytosterols, which is plant cholesterol, and your cholesterol in your blood, because the human body is actively designed to reject a phytosterol. When you ingest a phytosterol, when it gets through the brush border of intestinal lumen, there are mechanisms to spit it back. And you become less selective under two circumstances. One is when you're taking a statin. When you're taking a statin, you're actually reducing cholesterol production and hence LDL export through the liver. And so the body says, hey, I cannot make any cholesterol. Let me start absorbing more cholesterol from the food that this person is eating. And instead of just being able to absorb the real cholesterol, it becomes not less selective and starts absorbing phytosterols. So there is enough clinical evidence that when you're on a statin, the levels of phytosterol, like cytosterol, goes up. And the more plant-based food that you eat at that time, the likelihood of phytosterols going up is higher. And phytosterol is not the kind of cholesterol that our cells need, because when it's in our cell membrane, the cell membranes are rigid, they don't function properly.
So sorry, just to clarify, Nadir, so what you're saying is the plant sterols, the phytosterols, they're physiologically incompatible with our human physiology. They don't work in the same way. They disrupt our normal functioning. Is that understanding that correctly?
Absolutely. There is genetic disorders in which people absorb too much phytosterols. It leads to fragility of the cell membranes. It leads to different kinds of red blood cell disorders. And that's just the tip of the iceberg. The subclinical manifestations of high levels of phytosterols is perhaps atherosclerosis, perhaps degenerative vascular diseases. There is no real interest of looking into it. And so I'm glad that Zoe is bringing that up from a different perspective. I think that the dangers of phytosterols or plant cholesterols should be properly put out for the general public, and we as a community can do that. I'd also like to add a little comment about the LDL and statins and PCSK9 inhibitors, because as Gary pointed out, there is a huge conflict of interest from professionals, from the FDA, from the pharmaceutical industry, from the food industry to promote it. But also, just imagine the collective victory, like David Unwin says, between the patient and the physician. The patient comes back after taking a statin and their LDL levels are 50% low, 60% lower. They both rejoice in that collective victory, which is misplaced. And it feels like you have achieved something. And in that patient-physician interaction, everything is missed. Hey, do you have myopathy? Do you have cognitive issues? Are you heavier now and less active than before? Are you more insulin resistant? Do you have visceral obesity? These are all the side effects of statins that are completely ignored in that encounter between the patient and the physician, between the individual and the healthcare provider.
There's an enormous burden here on the physician to actually say, I'm sorry, I got that wrong. I have caused you harm. And that is a major ongoing problem I see for doctors around the world. Say, oops, I got that wrong. My credentials here, I used to be the cake judge at the hospital, and I got that wrong. I wouldn't take plasters off unless you actually brought me a chocolate cake. I'm sorry, I got that wrong. But the moment you can actually say, I got it wrong, you can move forward. You can, we discipline, tell our children, don't tell lies. Yet we see health professionals every single day telling lies, and I suspect more and more of them knowing that they're telling lies, but don't actually come along and say, oops, I'm sorry, I got that wrong. It's a major turnaround time. But as Tim Noakes has said, should not be a single doctor in South Africa who hasn't heard about low carb in the management of diabetes. And I'd like to think the same thing's happening here in Australia, particularly with James Mookie's work over the last year. And it's the same thing's going to happen, will happen with statins, that we as a health professional are going to have to say, sorry, we got that wrong. I can't wait.
Well,
if I could
agree.
Maybe I could expand on the comments by Nadir as well as Gary. First, just a bit more about the statins. There was a very important paper that was published about a decade ago, and it's been completely ignored. And it was published in American Journal, I believe, Geriatric Pharmacology. And you have 75-year-old people, men and women, all reporting cognitive deficits, all being diagnosed with early dementia. And they all were taken off their statin. And within about 6 weeks, the dementia had dissipated. Dementia was gone. Their cognition improved. And the critical finding is that there was a re-challenge. All were put back on their statin, and all now once again are diagnosed with dementia. All had impaired cognition. And we published a paper that showed, based on FDA adverse reports, that the statins that are associated with adverse cognitive events are the ones that can access the brain, those that are lipophilic, such as Lipitor. So Lipitor, you see far more adverse cognitive events compared to Crestor, which has more difficulty to get into the brain. And we need to understand the brain makes its own cholesterol. It controls the amount of cholesterol it has because the brain needs cholesterol to make new neurons, to make synapses, and to make memories. So when you take a statin that can access the brain and interferes with the brain's machinery to make cholesterol, you're interfering with essential brain function. And I think it's a travesty, actually, that there's been no follow-up study. And that's not cited by the American Heart Association when it reviews statin adverse effects. As well, diabetes is brought up with statins, and this is also minimized by American Heart Association. But I think the best study was conducted by Cederberg, in which they did an RCT and actually had people, none of which had type 2 diabetes in the beginning of the study. 6 years later, the placebo group spontaneously developed diabetes, about 5% of them, and the statin group developed diabetes in about 11%, where it's about 6% to 11%. So there's an additional 5% of people who are developing diabetes, which is associated then with taking the statins. And now, of course, that's increasing their susceptibility to every Western disease. as a result, clearly taking statins. And we know statins interfere with pancreatic function. That contributes then to the increased incidence of diabetes. And if I could also just elaborate, I think Gary made the important point. People started measuring cholesterol in the 1920s. And it is a fact that when you see someone die of a heart attack in their teens or 20s or even 30s, very often they have extremely high cholesterol, and that's became familial hypercholesterolemia. We know they have a genetic disorder in which you have impaired LDL binding, and these people have extremely high cholesterol. So when someone is 25 and dies of a heart attack, they typically have high cholesterol. But we have looked at the literature. We have published papers that show that there is something else that's crucial. The subset of people with FH that are dying young are the ones that have high clotting factors. So there are really two components to FH. There's the high cholesterol, which turns out to be a red herring. What these people, a subset of these people also have, is that they have extremely, for example, high fibrinogen, which you find in non-FH, normal people as well as FH. And that goes for homozygous FH as well. These people can die when they're 15. But these people have extremely high fibrinogen, which has been ignored entirely. And we compare side by side. This is 40-year-old literature. The subset of people with FH that die prematurely of heart disease are the ones that have more clotting factors. And now those clotting factors I'll add as well.
Sorry, David, I just make the point, just for people who are listening too, that a lot of the data that's putatively used to support the prescription of statins is based on populations that have a disproportionate number of people with familial hypercholesterolemia. This is the prototypical patient who's meant to benefit from statins.
And this is where the great fear of cholesterol comes as well, because these people come into the physician's office and they'll have cholesterol that's 400 or 500. And so they're told you must immediately go on some form of cholesterol lowering medication. But what they should really be looking at are the clotting factors, because ultimately I see the real trigger of heart disease has to do with hypercoagulation. And now what else adds to it? And again, the subset of people with FH have extremely reactive platelets. It's remarkable. You put adrenaline on platelets and what will happen is they will clump, they will aggregate. Well, the person with FH that's developing heart disease is 100 times more sensitive to adrenaline than a normal person, a non-FH person. And so this is where stress connects to heart disease. It is the increase in adrenaline which activates the platelets, which then contributes to development of stroke and heart disease. Cholesterol,
so I have a question
again,
for you, David.
is a bystander.
If LDL doesn't have direct correlation to this thrombotic tendency, this tendency to form clots, then is there anything in the lipid panel, and I'm referring to here what's known as atherogenic, the profile of low HDL and high triglycerides, is that associated with hypercoagulability? And if so, do we understand the mechanisms?
Well, as you've lectured extensively on the small versus the large buoyant LDL, what you find is an association of the small dense LDL with heart disease. And it exists in a metabolism that has the high triglycerides and low HDL. I would say now, I think it's a great question. Is a high level of small dense LDL, high triglycerides, and low HDL, is that found in conjunction with elements of hypercoagulability? And I have to say at the moment, I don't think people have looked at that question. There is an insufficient amount of work associating coagulation factors with lipids. And it's really fallen out of favor. The work that was done on platelets in FH individuals, you really have to go back 20 to 40 years. Frankly, there just isn't much money to giving someone with FH aspirin. I mean, the whole industry has gone to giving them statins and the PCSK9 inhibitors. You see almost no measurement of clotting factors. So off the top of my head, I don't know, frankly, I may have published it, but I'm forgetting it. But I don't know of an association of small dense LDL with greater clotting factors or clotting potential, but I would predict there would be.
David,
I
which
would, I
test
would chime
would
in
you be?
here.
All right.
Go ahead,
Go
Nadir.
ahead, Gary.
No, I was just
So
going
I
to
would
say,
chime in
which
here.
clotting factors would you be doing? Sorry, I'll back off.
Well, let me just
Nadir.
quickly say, the one that's been studied the most, that I'm most familiar with, is fibrinogen. And you see whether it's homozygous, heterozygous FH, or the general population, there is an extraordinary correlation between resting fibrinogen levels and coronary heart disease and stroke, basically from people from 40 years of age on. It is one of the best measures to predict both stroke and coronary heart disease.
Do you think that LP little a, being a breakdown product of this whole cascade, that could just represent a surrogate marker by association of an increased thrombotic tendency?
Oh, no, really good question. So LP little a is actually involved in as a coagulation factor. LP little a is very similar to one of the clotting factors itself, and the higher LPA appears to mimic actually the hypercoagulation effect. And actually, it's not a coagulation factor per se. What high LP little a seems to do is reduce fibrinolysis, the spontaneous breakdown of the clots. So it's clearly involved in the hypercoagulation process.
And if I could just ask for an opinion, I've got some perspectives on LP little a that are not widely shared. And I'll just, as experts, tell me if I'm barking up the wrong tree here. So a lot of people like to associate LP little a with an increased risk of death. And basically what it is, we've got an LDL particle that's got this lipoprotein A attached to the ApoB100 moiety that sits in the coat. And we've got a lot of data that suggests that the little a will only attach to B100 if the B100 is oxidized. So in effect, it seems to be that the LP little a is representing degree of oxidation. But when we actually measure it, what we really care about is the number of LDL particles that are actually oxidized, and that will be given by the particle count of LP little a. But when we do the blood test, we don't do a particle count because that's too hard. Well, it's possible. It's just cheaper to do another way. What we actually do, we get all the LP little a and we chop it up. And then we assume that your LP little a is a certain size, and we divide it by this arbitrary number, and we come up with a result. And we know that the length of this molecule is actually genetically determined. So if you have a genetically longer one, then you'll have a high reading. If you've got a genetically short one, you'll get a lower reading. In effect, it'll be false negative results. So people are correct when they say it's genetically determined in terms of volume. That is absolutely true. But in truth, the factor of this measure that confers the risk is the number of attachments, the number of LDL particles which have the LP little a associated with it. So, and until we start doing quantitative measures where we actually count rather than guessing at what people's genetics LP little a size is, the test is always going to be unreliable.
Go ahead, Gary.
I can remember that conversation on a phone call with you some months ago, Paul, and I still didn't quite understand it fully. But again, we're caught up with doing tests and trying to find surrogate markers to support an industry where I think we've just gone down the wrong path. And, because what we're talking about here is, a first world problem of being able to test this material. And it becomes interesting when the big picture stuff is if we could get 50%, 90% of the population to reduce their ultra-processed food intake, then all these things will align. And I'm fascinated by the topic, but I'm also caught up with which tests are we going to do, which ones can we apply when we've got a finite resource. And I'm still caught up on the whole inflammatory model of cardiovascular disease. And I think you're right, it's about the oxidized amount. But how do we measure it and then extrapolate it backwards to preventative health measures.
I'll yield to Nadir if you would like to comment, but I also want to comment on this.
Go ahead,
I'd like
David.
to make 3 comments here. But, I guess I am not. Are you able to hear me?
Yes.
I'd like to make 3 separate comments out here. So number 1 about the hypercoagulable aspect that you talked about with high triglycerides and low HDL. And I'm not sure that we really need to invoke that at all, because a high triglyceride, low HDL, a high LDL small p is a very hyperinsulinemic situation, which is causing hypertension, because high insulin causes blood pressure, it causes microvascular damage. So you're getting vessel wall damage that is then going to lead to atherosclerosis. So it's not necessary to invoke a hypercoagulable state in a disordered lipid metabolism that Gary has completely pointed out. We were not genetically designed to eat this much of processed food that has led to that. The second point that I would like to make is that either LP or LDL as a culprit in anything. I want to have a paradigm shift in the thinking of all physicians, all healthcare workers, that LDL is a molecule that comes in to dampen inflammation, to protect us from injury. So it is a firefighter, it's not an arsonist. And even oxidized LDL, because if you look at LDL, it has a high amount of many antioxidants, CoQ10, vitamin E, the phospholipid membrane. These are all trying to dampen inflammation at a site of vascular injury, and to consider that as a culprit, or even consider LDL as the culprit, is wrong. And the way the body clears the oxidized LDL is very different than how we clear a regular LDL through the LDL receptor. The oxidized LDL is no longer recognized by the LDL receptor. It goes completely different channels, like through the macrophages, so that you are clearing away a molecule that has done its job in protecting the host. Finally, with regards to Lp(a), it has several of these kringles which dampen fibrinolysis. And the information about Lp(a) is perhaps as contextual with inflammation as it is with LDL. In the setting of inflammation, this is perhaps a molecule that is increasing coagulation and perhaps contributing to some aspect of vascular disease.
Sorry, just to interrupt there, Nadir. Just to clarify, so when we're talking about fibrinolysis, we're talking about the breakdown of clots that are already formed. So this relates back to what David's already said, that saying it's actually the prothrombotic, or the tendency to form blood clots, that appears to confer risk to those with familial hypercholesterolemia. And what you've just told us, Nadir, is that this Lp(a) appears to actually impair the body's ability to break down clots once they're formed. So, you know, whether this is a problem of excessive clot formation or deficient clot breakdown, either way, the problem is the same. We end up with too much clot. Carry on.
I agree. But if you follow some of the work that Siobhan Huggins has done, that Lp(a) is perhaps more potent antioxidants that we have. And it's present at the site of injury, not to cause trouble, but to dampen inflammation and repair the tissues. And it's a paradigm shift that the whole medical field needs. And owning up, like Gary says, that I am so sorry that for 50 years I have led you down the wrong path. We need to have a completely new thinking about what the lipoprotein does for the human body.
if I might add as well, the cardiologist, certainly not Nadir, but your typical cardiologist views LDL, and I've even heard this, as a toxic molecule, that it is an atherogenic molecule. The immunologist views LDL as a crucial part of the immune system. LDL basically is used to eliminate pathogens, viruses, and bacteria. It's the savior for the immune system. And it's represented best when you look at elderly people who are 70 years of age, who have astronomically high cholesterol, have a 40% reduction in death. Overall, all-cause mortality in the next 10 years, from 70 to 79, they're significantly less likely to die. And overall, people with extremely high LDL have a lower rate of death after their age of 60 years. And we publish part of this, and this has actually been published, genetically confirmed FH. People have a lower rate of all-cause mortality, primarily because they have a dramatically lower rate of cancer and death from infection, and they have an average rate of death from heart disease. And here you're looking over decades. So LDL, there's nothing evil or inherently atherogenic or harmful about LDL. Now, when Gary mentioned markers, I do think markers are very important. Markers helped me to realize that my diet was off because my triglycerides were too high, my HDL was too low. And so therefore I learned how to change that with diet. I've learned from Paul so much about, you've lectured on the small dense versus large point LDL. I think it's important to know your small dense versus your large point LDL. Are you type A or type B? Because I think that you don't want to take medication to change your small dense or large point. You need to change your lifestyle. So those markers can tell you if your metabolism is off. If your blood pressure is high and your blood sugar is high and your small dense LDL is high, well, that's telling you to change your lifestyle. And I emphasize to people, good health is not in a pill. What you got to do is change your lifestyle. So I do think there's value to the markers. And I think the LP little a, by the way, there's just not enough measurement of LP little a with low carb diet work. I know of only one study by Jeff Volek in which they measured LP little a with people before and after they're on low carb, and it dropped. It dropped significantly. But that was not ideal because it wasn't terribly high to begin with. But I do think that's an important marker if we ultimately get back to, again, coagulation potentially along with inflammation as a trigger for atherosclerosis.
Look, I think some important points there. So first of all, you're saying it's the bigger picture of risk assessment, which is exactly what Gary started off by saying. Agree with that. The LP little a reducing on low carb diets, I see that in clinic all the time. I guess the key is that you need to see the trend, because if you just have a single value, you don't know how much of that value is genetically determined and how much of that is oxidatively determined. If you have a trend, then at least you'll know if you're getting better or you're getting worse. So that's what how I cancel my patients. I cancel them that if you want an LP little a, it's a private test and you're happy to pay for it, sure, I'll order it. But if I have one, I'm not going to tell you what it means. You need at least two. It's a trend.
Right.
Now, I just want to talk about oxidation. So Gary also mentioned oxidation earlier, and we talk about small dense LDL and glycooxidation stress. And it's my personal belief that oxidation is actually the root cause, as closer to a single root cause of atherosclerosis as we can be. And it may even be that it leads to an increased thrombotic tendency, as you've already discussed, David. So if we have a condition like Gilbert syndrome for an Aussie, or if we're a little more educated, we call it Gilbert syndrome. This is a condition where we have elevated levels of bilirubin, and we call it a syndrome, like it's a disease. And bilirubin is a potent antioxidant. And it just so happens, as I'm sure you're all aware, that people with Gilbert syndrome have approximately a 50% reduced risk of heart disease. And I think, if nothing else, this really should lead to food for thought. Why exactly does an elevation of a potent antioxidant reduce our risk of dying of heart attacks? And I guess on the flip side of that, I've also made the observation that when I have people come in with terrible LDL profiles, they've got horrible amounts of small dense LDL, and they've often got very high triglycerides. I noticed that they had very high levels of ferritin. And I thought, well, what goes on here? And then I look in the literature, and as you're probably very well aware, hypertriglyceridemia completely associates with a condition called hemochromatosis. So I looked into hemochromatosis a little bit more, and I actually was educated by my good friend Pran Yoganathan, and he told me about the genetics of hemochromatosis. This is a gene that increases iron absorption into the body, and it appeared to be selected for evolutionarily when societies went to grain-based agriculture. They went away from these iron-rich animal-based diets, evolutionarily appropriate diets, and they started consuming iron-deficient grain-based diets. And it appears that about that time in populations all over the world, when that transition was made, there became a positive selection pressure for these genes, the HFE1 gene, hemochromatosis genes. And there's literally hundreds of these genes that have been described, although we generally think about them
around the
only
Mediterranean.
Particularly
around the Mediterranean.
So this gene is, you're not getting something for nothing. That's the whole principle of these genetic changes. So if we're absorbing extra iron, we've always assumed that iron, we know, has oxidative capacity. But if you're absorbing extra iron, at what expense? At the expense of what else? And two things that share the same transporters as iron are zinc and copper. And as you know, David, and I guess Nadir as well, you've probably read the literature, you've read it as well as I have, that copper is a stabilizing influence on iron. In the presence of copper, iron is much less oxidative. And it's actually been shown that when LDL that's exposed to both iron and copper doesn't really oxidize, but if you expose LDL to iron alone, in the absence of copper, then it does oxidize. So this association that I frequently see, and the reason I'm saying this, Nadir, is you talked about the nuances of some people who need different management strategies. They're not responding in the same way as everybody else on a standard diet. If you're hemochromatosis, the problem is not an excess of iron, it's the fact that your iron is not being stabilized by copper. It's a relative copper deficiency. And we know this to be true because when we venesect people, we take blood out of them and bring their iron levels in their stores, what we call ferritin stores, down to below normal levels. They still exhibit increased oxidative stress. So I might throw it open to discussion. So my personal belief is that oxidation stress is the root cause of atherosclerosis. And if we were trying to target something as a root cause, that's where we go.
I couldn't agree more with what you said. Go ahead, David.
Go ahead. Well, I'll just add, I think there are numerous root causes of heart disease. We should also consider glycation as, in a sense, a damaging of proteins all over the body. It's most obvious when we look at glycation of hemoglobin, but glycation, as far as I understand, is about one of the only non-enzymatic reactions in the body, that the glucose molecule literally can attach to almost any protein in the body. And that's what we're measuring with A1C, is the glucose attaching to hemoglobin, which is also why you see proteins degrade all over the body. And of course, you're experts. This is why people with diabetes have so many diseases, because their proteins are damaged by glucose. And so you have glycation of LDL as well. You have glycation essentially of so many different proteins. And as I understand it, the worst possible combination is called glycoxylation. You have not only oxidation of molecules, you will have glycation of molecules. And so this is really the worst possible metabolic scenario in which you have essentially a defective home with gasoline poured all over it, and it isn't much to light a match and have that home burn up even more quickly. So I would agree with you, although I don't fully understand how we increase oxidative potential. Let's connect that to lifestyle. But what's very clear is we know how we increase glycation, and that's with chronically elevated glucose.
And what I'd
Don't know
like
if
to
you-
add about the nuances.
Go ahead, Nadir. You're on mute.
Yeah, what I wanted to add about the nuances was a slightly different scenario. And that scenario is one of a person who comes in who is severely insulin resistant, hypertriglyceridemic, with significant amount of visceral obesity. And these are the people that I get a little concerned about when I tell them that, hey, I want you to go to a low carb, high fat diet. And the reason for that is that their fat cells are already overstuffed and filled. They have visceral obesity. They are not programmed in that metabolic situation to handle the amount of fat that we give them a license to eat immediately. So these are the people I would say that, hey, look, at this time, you're perhaps better with a low carb, sort of a low fat diet if possible, mostly lean meat and lean protein with a huge emphasis on fasting. Because if you're not emptying your fat cells, if you're not removing fat that has accumulated in your pancreas, then adding more fat would add a little bit of fuel to the fire that you're not going to get metabolically healthy, because that is where you would get into lipotoxicity. And that is the kind of modification that we need to make. And many of these patients come in, and I think that as humans, we are genetically programmed to overeat even the good stuff, even meat and fat and animal sourced food. And I have had a number of patients over the last 8 years who are not able to lose weight, able to get metabolically healthy. And these are the people who need hand
Sorry,
holding
I'll
and
just
proper
interrupt
tracking.
there, Nadir. So can you just elaborate, when you say we're genetically programmed to overeat, could you just elaborate on that in the context of we don't really see obese animals in the wild?
Well, obesity happens in whenever there is significant availability of food in a situation of a modern society. And humans are, if you look at our genetics, and I've just recently done work on this, as soon as we start eating, our ghrelin levels go up significantly. They peak within a few minutes. Even the thought of food starts the rise in ghrelin. And ghrelin levels do not come down, and this is the hunger hormone. It does not come down for over 1 hour. And I have observed this not only in myself, but in several of my patients. They come in and say, hey, I have eaten and I know that I'm full, but my brain tells me that I still I have a desire to eat more. And that desire will not be present in an ancient world in which you don't have a supermarket and a fridge, because there was not a guarantee that food would be available to us all the time. And because of that, most animals were designed to overeat when food was available so that they could survive through periods of scarcity. Humans are also programmed like that. And we live in a very different conditions than our ancient ancestors lived. And perhaps some of us are genetically more susceptible to overeating than others. And that's the kind of group that we need to advise better. And we shouldn't tell them that, hey, look, we told you to do something, you're just not doing it right. Because as clinician, I come across many patients who say, I have done everything that you told me, but I'm still not successful. And I think those are the people in whom we need to program them to say that, hey, you are genetically designed to overeat. You need to somehow figure out how you can program your brain to eat the right amount of food.
I would
Thoughts,
like
Gary?
to comment. Or go ahead, Gary.
Paul, just coming back to your previous sort of comment, question, statement. I've come from the back. My whole background in nutrition now, I suppose, has been based on this inflammatory model of modern disease. That inflammation sits behind it as the root cause, and that's why I took a different tack with my talk yesterday, which was really to actually say, let's take an academic argument to say what is the toxic dose of carbohydrate, because glucose and fructose, the body does everything, rather than seeing them as actually positive things, think about them, why the body does everything in its ability to get it out of the bloodstream right from the word go. So before there's oxidation, David's quite right. The moment blood glucose goes up, you can start getting glycation of proteins, and those proteins are throughout the body. And other damages that's occurring to the glycocalyx within seconds and minutes. It's got nothing to do with oxidation and inflammation. The oxidation is a secondary process, but that's what I found fascinating, is that we know that the direct causes of fructose, and it's been widely described, and Robert Lustig's seminal work there based on who's the guy in Switzerland? Got a blank on his name. It'll come back to me. But essentially, there are direct toxic effects of glucose and fructose, which are there on our tissues and particularly on our blood vessel walls, on the glycocalyx, within seconds of it hitting it. And the oxidation, which is the secondary effect, I think is, so it's bloody complex in Australian terms, but literally it's not just oxidation, it's not just glycation. It's, it's clearly tied up with the excess of processed food since the onset of the agricultural revolution, compounded by the industrial revolution, and now what I call the processed revolution. And it's almost my closing statement for you.
David?
So I do want to comment on Nadir's perspective. And I am obviously, I'm not a clinician. I don't see people having difficulty with low carb. This is based solely on my reading of the science. And we go back to one of the first low carb trials, which was run by John Yudkin around 1960. I believe it was Yudkin. And he said it should not be called a high fat diet, because when they monitored what people ate, they found that what really happened was they lowered their carbohydrate consumption, and they actually ended up eating about the same amount of fat that they had consumed before. And when you look at the methods of virtually every low carb trial, people are not told to restrict calories. They're not told to restrict fat. They're told to restrict carbohydrates. And what you find is a spontaneous reduction of total calories. You find relatively stable fat consumption, and the real reduction, not only in a meal from carbohydrates, when you monitor calories over a 24-hour period, you find that despite the fact that people are told you can eat as much protein and fat as you want, people actually overall consume fewer calories. So your concern that people would eat too much fat, at least from the literature perspective, is that generally doesn't happen when people go low carb, unless they're attempting to go out of their way and gorge themselves with fat, which really is inappropriate. The other thing is there are mechanisms that come into play, and clearly there are genetics involved here that produce this powerful satiety. The reason why people eat less on low carb is because, and it does take a half hour to an hour, I feel it myself, after a meal of protein and fat, it almost feels aversive to want to eat more, and that lasts for many hours. So there's a powerful satiety trigger that's involved with consuming fat and protein. So I don't think in general that your concern about too much fat consumption is warranted. I think when people naturally cut back on their carbs, especially if they're going ketogenic, then they will naturally also restrict fat from being overly consumed.
Well, if I can...
Let me just add one more thing. Yes, people will plateau. And I think at that time, intermittent fasting may actually help to boost to get to a newer, lower level.
Thank you, David. So I have to say, I agree with both Nadir and David on this one. So how on God's green earth can I do that? Because I have two types of patients. I have patients that follow the science perfectly, that show that when you eat to ad libitum, basically eat as much as you want, but eat healthy food, your appetite is incredibly well controlled, and bang, you lose a huge amount of weight. And on average, we know that these patients lose so much weight that on average, in any study you do, which is we've seen time and time again, the high-fat diets are superior to low-fat diets in terms of weight loss. And that's been proven in, as far as I know, in every single randomized controlled trial that compared two diets head-to-head. Now, but what Nadir is talking about is these patients who still overeat, and there still are those. And I believe that we need to distinguish between what's hunger and cravings. So we also have addictive type of eating behaviors, and I'll just discuss it briefly now, is that often one thing that carbohydrates and food does for us, and I'm sure you've read the book, Salt, Sugar, Fat, these great book about the bliss point of food and how the modern food industry manufactures food to be incredibly rewarding. What does that mean in a chemical sense? That means dopamine in the brain. Now, humans are hardwired to want dopamine. Human survival is predicated on behaviors that release dopamine into the brain. This includes procreation. This includes eating. We are literally hardwired for this. So if we have any issue within our physiology that precludes us from producing dopamine or other neurotransmitters at an appropriate level, we're going to have a deficiency and understand we're hardwired to chase these chemicals. So what could cause deficiencies of these chemicals? Well, if we call them catecholinergic neurotransmitters, there's dopamine, there's serotonin, and there's noradrenaline. And they all require nutrients like vitamin B12. And so if you're deficient in that for whatever reason, be it an autoimmune condition or just say a vegan diet, then you'll have lower neurotransmitter levels, you'll have lower dopamine levels, you'll have this drive, you'll to eat foods when you're not hungry, because you're not chasing hunger, you're chasing dopamine release, you're chasing that warm embrace that sweet foods and carbohydrates give you. Chronic inflammation, because it sequesters iron in ferritin stores and makes it unavailable within the serum for use. So yes, the amount stored in your body goes up, but it's not available to be utilized. We know that when we inject people with inflammatory chemicals, we can halve the circulating iron by 50% in 2 hours' time. So people with chronic autoimmune inflammatory conditions find that they have this functional iron deficiency, and iron is a necessary cofactor for the synthesis of these chemicals. And in that situation, if you're deficient in neurotransmitters, then yes, of course, then you will eat something sweet. You're hardwired to chase these chemicals. And then, just as an aside, people are wondering, well, why don't we just take antidepressants? Because antidepressants, the way they work, they don't increase the production of these chemicals. They just preserve what's there for a little bit longer. But if your production is really clapped out, then, just because you preserve a little bit longer doesn't count at all. So that's why the science is absolutely correct. We do know that deficient neurotransmitters is the underlying pathophysiology of depression and anxiety. It's just unfortunate that the drugs we give don't treat the root cause of it, which is usually, it can be nutrient deficiency, it can be chronic inflammation, so on and so forth. And that's why, these drugs are only effective for a small minority of people when we actually look at it. But when we treat people's chronic autoimmune inflammation, their mood often significantly improves. So I'd suggest, Nadir, next time you're having these patients who are overeating, don't just look at it in terms of an energy in, energy out perspective. Maybe consider it from a neurotransmitter perspective. So I can actually do serum serotonin levels on my patients, and I actually see that when we treat them over time, that their serotonin levels actually increase. And they've done studies in patients with celiac disease where they've actually taken the fluid from around their brain. It's called a lumbar puncture, and they take the cerebrospinal fluid, and they've actually found differences in the serotonin level when they're on a gluten-free diet or when they're not on a gluten-free diet. So this is absolutely a very real construct.
Let me elaborate on what you just said, Paul, and lead to a question for Nadir. So you're absolutely right that sweet foods, and actually the combination of sweet and fat, is powerfully rewarding and has been shown to increase dopamine. The dopamine actually increases in anticipation of eating the food. That's part of the craving. But what I would predict, and I ask this of Nadir, is if you eliminate the sweet foods, which is the essence of low carb or even ketogenic diet, what I would wonder is in your patients that are failing to lose weight, that are overeating, are they actually producing ketones? Are they ketogenic or are they cheating? And so if they're eating a combination of carbs and fat, that's going to interfere with their weight reduction. My prediction is I would be surprised if they're producing ketones and they're saying they're overeating.
So absolutely, I listened to all of your comments, but I was talking about a specific subset of patients, and to these patients, we advise them bulletproof coffee with high amount of heavy whipping cream, fat bombs, and these people are already hypertriglyceridemic. They already have stuffed fat cells. They have visceral obesity. Their pancreas is not talking properly because the insulin producing cells do not actually communicate with the glucagon producing cells. So in these people, even though you are making ketones, you still have high triglycerides, you still have high sugars, because even though they eat a protein-rich meal, their insulin goes up, but their glucagon skyrockets. And when glucagon skyrockets, it's converting all the protein that you have taken into glucose. So there is a subset of patients who are insulin resistant. And one of the things that we need to recognize is that years and years of insulin resistance and visceral obesity causes a fatty pancreas. And that fatty pancreas is unable to correct metabolism properly without some degree of a fast that removes fat from their diet. So that's the group of patients that I deal with, and I think that we need to advise them differently.
Can I put that in lay terms to summarize? This is my take on what you've all said, and obviously it's my opinion, so apologies. When you take modern food, particularly sugar, fructose, glucose, and refined carbs and polyunsaturated oils, that has significant behavioural change. It drives behaviour. When you reduce that, particularly the sugar component, you allow people to eat to their nutrient requirements rather than their caloric requirements. And so once you actually, I'll use the pizza example, you can have an enormous amount of pizza. It's got all sorts of colours. It's got an enormous energy requirement, but it hasn't fulfilled any nutritional requirements, or not to requirements. So what do? You want to eat another one. So the take-home message for me is when you reduce processed food, particularly the sugar, particularly that fructose, you then start eating to your nutrient requirements. Your body will tell you you're hungry. You've stopped that overeating. And on the majority of people, and I agree with you, Nadir, there's a whole subset of people that doesn't work with, they end up reducing their caloric intake. So you've got a lower caloric intake. So it gets said, oh, low carbs, low calorie. It's low calorie because you end up there.
Okay, so I think that's
Paul. Oh, sorry,
David,
go ahead.
carry on.
Well, I did have a question for you. Oxidation. I haven't seen a lot of work on how we either increase or decrease oxidation of our molecules, particularly LDL or any other molecule. So how does lifestyle, or how does low carb diet, how does sugar specifically affect oxidation? And are there studies showing that low carb will actually change oxidation in general? And how does one measure it as well?
Okay, so I'll be brief because we're getting a bit long in the tooth here. So first of all, it's very difficult to tease apart sugar and oxidation. So we use the term glycooxidation to reflect what happens to LDL particles, where we use them almost interchangeably, because fluctuating blood glucose level generates oxidative stress. This has actually been shown. So when we measure people's blood glucose trace, people with an average blood sugar level, even if it's higher, if it's stable, they'll have lower oxidative levels circulating than people who have an up and down one. So and I have come across the mechanistic data having a look at mitochondrial metabolism that shows that the fluctuation in fuel supply, high glucose, low glucose, actually leads to the mitochondria actually generating extra reactive oxygen species. We also ingest a huge amount of oxidation, so we can actually, when we absorb lipids, when we absorb fats from the diet, so when we're consuming seed oils, by definition of them having double bonds between carbon atoms that are prone to reactivity, we're ingesting oxidation products, and these get directly incorporated into our chylomicrons. So if we did a non-fasting blood test, and there's been studies that have actually done this, and we actually measure the level of oxidation being incorporated into the chylomicrons, we actually see people who are ingesting seed oils are actually ingesting oxidation products. These oxidation products eventually find their way to the liver. We've got mouse studies that show that when you deliver oxidation products to the liver, it actually causes fatty liver disease, which is then sequentially leading on to insulin resistance. And as you talked about before, Nadir, all these other things on insulin resistance and all of that, well, these are all very interconnected. So we've got I think quite a convincing amount of data that oxidation is both sugar-related and seed oil-related. And then to add insult to injury, they did a beautiful study where they actually gave people oxidized oils. And when I say oxidized oils, that could be any seed oil, because they're all oxidized, I promise you. There's no way you can stop them from oxidizing. It's a chemical reality. And they actually had people in 3 groups, so non-diabetics, well-controlled diabetics, and poorly controlled diabetics. And then they measured the level of circulating oxidation products within their circulation. And they found that for the well-controlled diabetics and the non-diabetics, they had quite low levels of oxidation products that were pretty much cleared from their circulation within about 8 hours. For the poorly controlled diabetics who had these higher up and down levels of blood sugar, their oxidation products persisted for 3 days. So it is absolutely the interaction between the two. And I was perhaps being a little bit mischievous before, where I just mentioned oxidation in isolation. Of course, sugar control is absolutely important. And the reality is we can't tease them apart. In effect, one can cause the other.
Right. I knew you were being naughty, okay?
So, look, I'd just like to, a couple of comments. So Amber Ahern, who is absolutely fabulous, one of the most deepest, most creative thinkers I know, has made the comment that plants are largely treated as toxins by the human body, and that relates back to the original comments about plant sterols. They're really not a part of mammalian physiology. I think it's important that we don't forget that. We're probably running over, so just to answer one question here from another favourite person of mine, Dave Feldman. Have we seen much CT angiogram data on our lean mass hyperresponder patients thus far? So I don't know, Nadir, talking about, I guess, the lumen, the size of the opening in the blood vessels, and whether we have any coronary artery calcium score data, have you seen what progress have you seen in your patients in those metrics?
So I can only give anecdotal information. I have not seen large studies in this anywhere. And I think that we are being overtly simplistic by saying that when you go on a low carb diet, your triglycerides fall, your HDL increases, your LDL increases. And by the way, the inflammation markers like CRP and GGT and serum ferritin go down. And this has been shown not only in many clinical trials, but also in my practice, convincingly. And we would expect that this group of people, the so-called lean mass hyperresponders, would have a stability in their calcium score. Either they will remain 0 or if they were at some level that they would not progress. And the important aspect here is to recognize that after having done CT calcium scores for about 5 years in my clinical practice, I still see a subset of people progressing. Their calcium score increases. And that is where I want to make a very important comment that human biology is inherently very complex. And when you are dealing with complex systems, an outcome such as coronary calcification is inherently unpredictable, because it's not just LDL and our metabolism that's going to lead to coronary calcification. It's going to depend on how well we sleep. What is our stress level? Are we exercising to a level in which we are not causing a heightened adrenergic state? Is it an optimal level of exercise? So there are several different variables that would cause vascular disease. And for us to be just simplistic and say that we have the ultimate cure is wrong. I think it's part of the puzzle. I would much rather be having high LDL and low triglycerides and high HDL and say, yes, I'm going to protect my coronary arteries. But to say that that is the sole answer would be wrong. And if we see a group of patients who are low carb and lean mass hyperresponders, and that they have a slight increase in their coronary calcium, we should not think that that is a failure. We just are dealing with a very complex biological system with an unpredictable outcome.
Thanks, Nadir. And just my own experience, like Nadir said, some people don't do well, some people actually progress, and they're the fun patients, because then we get to work out, are these the hemochromatosis patients? Do they have thrombotic tendencies? We need to work out why. Having said that, I've also seen people reverse, and I recently had a letter from a cardiologist advising me that there was a mistake with the patient's coronary artery calcium score because of the degree of reduction in a short period of 2 years. So he was actually trying to have it repeated. I have followed up on that recently, and as it turned out, it wasn't a mistake, and it was certainly eye-opening for this cardiologist. So I might just take some closing remarks, beginning with Gary.
I'm humbled to be part of All Stars International. Look, Paul, you've put together a great show. I've listened to all the talks yesterday, so far today. I'm still learning, okay? And that's the important thing for all of us. We are all still learning. We don't have all of the answers. I think we're in the right direction. Thank you.
David?
Just one fact, just to add on the coronary calcium, is menaquinone, vitamin K2, is very well associated with coronary calcium. So it appears to interact with vitamin D and making sure that the calcium is directed to the bones and not to the arteries. I also want to thank you, Paul, for putting this together, and I expect to watch all the talks. Ultimately, I assume that they'll be recorded and available. I'm honored to be with the three of you. Absolutely astounding. I have learned so much from you and from so many other people. And perhaps as a scientist, I've been a scientist for 40 years, and I never had any controversy being a neuroscientist. But one thing I think does come across in my talks, my entree to cardiovascular disease research, I sometimes, that antipathy I feel anger, and it comes across because I see how the field has been tarnished. People have been misled in this field in a way that I never knew. Even I had pharma funding in my neuroscience research, but to me there was nothing like the way the American Heart Association has been in bed with pharma, and they have such a great control, such a great influence over how people are treated. And this really comes across in my writing and in my talks. And I guess it's fortunate I'm not a clinician. I just get to say what I want, and I give no advice, just information.
Thank you, David. Nadir?
Well, I'm simply honored to be on the same stage as the three of you. And it's a dream. I have to pinch myself that I'm actually on the same stage as all of you. My final comment that I'd like to make is that the change that Paul is so strongly trying to create through this conference and others, and I'm going to enjoy all the talks that have been put out, is actually should be directed as a grassroots effort. And the grassroots effort is what's going to change medicine. This is not going to come from top down. There is way too much money in and conflict of interest for physicians and major organizations to admit that they got the whole paradigm wrong. They're going to be forced to think in that direction from the work of Paul, from the work of Gary, in which general public is being educated and the gap between the so-called academicians and the general public is narrowing. So I applaud you for doing what you're doing, and we should continue our efforts.
Well, it seems that we've got a mutual admiration society all around here. Look, I'm truly privileged to be able to count you as friends. I genuinely appreciate your time for both your lectures and for participating in this panel. And I actually thoroughly enjoyed this discussion. And I absolutely know that we're going to be having a lot more discussions. And I'm hoping that we'll be able to collaborate on some future writings together as well. So I'll definitely be in contact. But thank you. Look, you have my sincere gratitude. Thank you so much. And back to the program.
Thank you.
Thank you.